Our topic today this might be a bit of a paradoxical picture. Here's a young lady celebrating her 100th birthday with a cigarette. So we can probably make all sorts of interpretations here about tobacco abuse or tobacco dependence, but maybe many of us would be secretly jealous that she survived to 100, whatever her substances are that she's using. And I always try and think what would sum up this presentation, and I've decided that maybe this would sum it up. You know, we've all been brought up with the aphorism, you cannot teach an old dog new tricks. But as it turns out, we have 3 dogs. We have one that's very old, and this dog, Flopsy, can still learn new tricks, although it takes a lot longer, and you really have to spend a lot of time. And I think where we're headed in this half-hour presentation is the old dog that we're referring to here certainly might be the senior patient, but as this proceeds, perhaps you'll see that maybe it's the family member, the caregiver, the physician, the pharmacist, the nurse. So we'll kind of put that at our place. So, a few guidelines. And the first one, you know, addiction knows no age limit. I have yet to find an age cohort or a profession or a gender or a race or a tribe that's immune from addictive illnesses. So simply the fact that we're getting older doesn't mean that we've now become immune to addictive illness. And the second piece could probably be a universal guideline for, my guess is, most of the presentations that are done here, which is whatever we see in a senior patient that appears to be pathologic, for golly's sake, please don't blame it simply on the aging process. Let's try and think beyond that. The third one kind of hit me right up the side of the head when I was tasked with this presentation, because I did what I always do, which is I plagiarize and I do literature searches and I do homework. And it's amazing, as I was studying this topic, a fair amount of literature from the mid to late 90s, some literature in the early 2000s, but very little since then. So this is truly a topic that, you know, hasn't been touched. So we truly don't know the extent of substance abuse by the elderly because it hasn't been studied carefully. And given that, you know, substance abuse always has to be considered a major cause of emotional and physical disability. And if you doubt that, I'll just simply say, talk to your friends that work as a doctor or nurse or technician in an emergency room, and they'll let you know that probably 30% of the folks that travel through an emergency room at some point in their travails there, substance abuse is playing a part. So, with no further ado, what's clear as you peruse the existing literature is that substance abuse in the elderly, and we're going to define that today as simply 65 and older, we're going to make that arbitrary designation, is one of the fastest growing health problems facing our nation. You know, and we know the cohort, you know, over 60, right now about 30-odd million, maybe 35-odd million, and by 2020 we're expecting that to be 60 million, so almost a fourth of our population. So a very large cohort that's growing very rapidly. And as you'll soon see, the use of drugs in this population, prescription drugs, is what we're zeroing in on today, is massive. And as I mentioned earlier, we haven't seen a lot of research on alcohol and drug abuse in the elderly, and there's a number of reasons here. Much of the research on alcohol and drug abuse is federal agenda. It's granted, it's funded, I should say, by the federal government, and they zero in on a different demographic, and they zero in primarily on illicit, illegal drugs. Second piece to this is that, we all suffer from the nice little old lady, nice little old man phenomenon. It's almost incomprehensible that these folks who have weathered many storms would be abusing substances, prescription drugs, or alcohol. So it's just really not in our radar, if you will. And the third piece is, in this country in the 60s, we went through a transformation. The drug era. You think about the history of our country in the 1900s through 1950, and alcohol. We went through a period of prohibition. Prescription drugs were relatively rare. Certainly illegal and illicit drugs were minimal. There were lots of religious proscriptions against it. Even here in the great state of Texas, we still have a number of dry counties. But all that changed in the 60s, and government funding kind of headed to a whole different section and a whole different population. But in terms of looking at drug abuse in the elderly, it's really kind of minimal research. The other piece to this is that compared to young adults, substance abuse in the elderly shows up as a medical or psychiatric condition, not as a florid drug problem. So it's somewhat disguised. But bullet 2 is, I think, really kind of the center of this. This is maybe a variation on don't ask, don't tell. Substance abuse goes undetected. The screening tools that clinicians use in younger populations may not apply in seniors. DSM-4 criteria, which is the psychiatrist's Bible, the diagnostic and statistical manual for abuse and dependence, which implies that abuse means continued use has adverse consequences, and dependence simply means that abuse leads to adverse consequences, and there's tolerance, and there's withdrawal, and there's loss of control. Well, those criteria are often applied to how people function socially, how they function occupationally. So what do we know about the elderly? Well, perhaps they drive very little, if at all, so they're not going to run into problems with DUIs, okay, very few problems. They're retired, so they're probably not going to run into problems occupationally. And because they're older and may have health problems, there may be very little social interaction. So the criteria that we would ordinarily apply in a younger population may not exactly fit in the elderly. And then the last one is kind of unwritten, unspoken. There's this sort of pervasive idea that substance abuse in the elderly can't be treated. And I'm not sure why that is. Maybe it's the assumption that we're in the 9th inning and there are 2 outs, and why bother? I hope that's not the case. In fact, that kind of goes to the earlier commandment, one can teach an old dog new tricks. But that's sort of a pervasive belief. Now here's the part that changes everything. I happen to be a baby boomer, born in 1952, and you can see the window that defines baby boomer, 1946 to 1964. That's clearly changing and will dramatically change the future clinical landscape in geriatrics, and especially in terms of substance abuse in the elderly. And the reason for this is this cohort of people grew up in a different time and place in terms of widespread use of prescription drugs that has little or no stigma because they are, quote, safe. A doctor prescribes them. This cohort grew up in the era where recreational and illegal drug experimentation was not morally prohibited. In fact, on some level, it was perhaps encouraged and flourished. So this population has experience with substances. This population is very familiar with prescription drugs, very familiar with illicit drugs. So there's a strong evidence that by 2020, the number of elders 50 and older that need treatment for substance abuse disorders is going to double and perhaps triple from where we're at in this is data from 2010. So the baby boomer cohort simply changes the landscape and will change the landscape in the future. So, moving down the line, right off the bat, there are some clear challenges here for discovering drug abuse and dependence in the elderly. First and foremost, elderly patients are less likely to report. Perhaps some of this is denial. You know, they've used substances, quote, successfully, unsuccessfully, so it's not a problem. Physicians perhaps have bigger fish to fry. We have to treat Mrs. Flabeat's congestive heart failure, her osteoarthritis, her COPD, so they're zeroed in on medical conditions first and foremost. And to ask screening questions, how much do you drink? Have you ever used any recreational substances? Do you use them currently? How much do you smoke? How much caffeine do you use? Is almost an afterthought. So we see consistent under-recognition and under-diagnosis. So I'm going to just pause here and kind of present in less than a paragraph a case, and that'll kind of guide us. So I saw a patient in 2009, a lovely 80-year-old gal who'd been married 60-some years, had 6 children, 9 grandchildren, and she came accompanied by 3 of her daughters. And the daughters were concerned about this patient's use of alcohol and medication. She'd had a number of falls. And she simply told me when I queried her about her use of alcohol and recreational drugs, caffeine and so forth, that she drank 3 or 4 glasses of wine a night with her husband, who she described as a career alcoholic, and that it wasn't a problem for her because she didn't go out. She said it might be if I went out to drive, but that was her habit. When I pressed her about how many bottles of wine a week that she finished, she told me 3 or 4. She went on to tell me that in the 70s she had experimented with barbiturates and stimulants, and had actually used quite a bit of alcohol until she got into a virulent argument with her husband, and she elected to go to Alcoholics Anonymous for a year and was abstinent for a full year. But she said she was now drinking to appease him. He was unwell physically, was wheelchair bound, and drinking was his, quote, only pleasure. So in short order, this gal probably wouldn't have reported so directly unless she was questioned, a bit like a police interrogation perhaps. And then the doozy came when I asked her to review her medication reconciliation, and she was relatively well physically, had some high blood pressure, some osteoporosis, but she informed me rather casually that she typically would take 40 milligrams of Ambien a night to get to sleep. And we'll leave this case here and we'll come back to it in just a wee bit. So we'll just kind of pause on that one, and I want you to remember this gal, okay? Now, drug abuse and dependence, for shortness, for the time allotted today, we've got to zero in on bullet 2. But drug types in elderly that we find abused and dependency creating are illicit drugs, marijuana, cocaine, inhalants, heroin, hallucinogens. Prescription drugs, and these are going to be primarily sedative hypnotics, sleeping aids or anti-anxiety medicines. They fall into the pharmacologic family of benzodiazepines, and narcotics, opioids, for pain management. Those are the two primary prescription drugs of abuse in the elderly. We can't neglect over-the-counter medicines, of which the elderly are far and away the greatest consumers. You know, these include sedatives, laxatives, and analgesics. And the presumption here is that they're over-the-counter, so they're incredibly safe. We now know better, to be sure. Elderly patients that abuse laxatives can quickly get into metabolic trouble and dehydration. Patients that abuse sedatives can certainly become toxic. And even analgesics, analgesic abuse can lead to GI bleeding and drug-drug interactions. And then lastly, we're in an era of complementary medicine, alternative medicine, and that's, I think, going to be a wonderful thing and an adjunct. But herbal medicines are not utterly benign. They often contain caffeine or ephedrine in various quantities. They have drug-drug interactions. But for today's purposes, we're just going to zero in on prescription drug abuse and dependence in the elderly. Part of the reason for that is abuse of illicit drugs is fairly uncommon in the elderly. Lots of ideas about why that is. Perhaps the elderly that began abusing illicit drugs earlier in their life, they're burned out, or perhaps these drugs have ended their life prematurely. And there's some data. Elderly heroin abusers, if you do community prevalence studies, it might be 0.5 to 1%. And when you look at elderly outpatient prescription narcotic abusers, it's 12%. But bullet 2 kind of speaks to what we hinted at earlier, that the elderly as a cohort use prescription drugs 3 times more frequently than the general population. Lots of reasons for that. And over-the-counter use is even more extensive. And here's where all this now kind of funnels into the perfect storm. I'm sure most of the audience has heard a number of times that as we age, our ability to metabolize medicines dramatically changes. And there's a host of reasons why. We know that as we age, our lean muscle mass decreases, our total body fat increases, our total fluid volume decreases. Our GI motility slows down, so drugs stay longer in our system and get absorbed for a longer duration, a longer hang time. Our kidneys aren't as efficient, and our kidneys help clear drugs. So what this creates is, as we age, we have decreased reserve to drug effects. We clear them much more slowly. And our central nervous system is much more vulnerable, much more sensitive to drugs and to substances. Maybe the summary would be a very little goes quite a long way. And then lastly, many of the elderly have comorbid medical illnesses. They take other medicines, and we now have the potential for drug-drug interactions. So perfect storm starting to develop. So little epidemiology. We know that 65 years of age and older adults take at least 83% take at least one prescription drug, and 30% of that population take more than 8. And of course, you say, what's going on here? Polypharmacy. Part of this is probably on the shoulders of clinicians, physicians, nurse practitioners, PAs, a failure to communicate. Mrs. Flebeat sees a primary care doctor. He refers her to a number of specialists. The left hand doesn't know what the right hand is doing. Hopefully that's getting less and less with the arrival of electronic records, but it goes on. Many elderly patients are started on a medicine, and it's continued for an endless duration. I always ask my geriatric patients on the second visit to bring in all the medicines they have in their cabinet, and we'll just take an inventory. This is the old brown bag sign. And it never fails to bewilder me that I'll find medicines there that are 10, 12 years old. The pharmacy label is yellowing with age. Yet it's still in their armamentarium, and they still take it on a very haphazard basis. And then really bearing down here, when you look at epidemiologic catchment areas with the elderly as a focus, what we see is a very high percentage take sedative hypnotics and a high percentage take opioids. And even when they're taken as prescribed, it's not uncommon for dependency and toxicity to emerge. So why would a wise, experienced older person abuse drugs? So a few thoughts here. Perhaps in some ways it's not terribly different from why adolescents abuse drugs. That may sound like an odd comparison, but let's walk this through. Both groups, remember those halcyon teenage years, both groups have to navigate, very changing roles. The adolescent is now emerging independence. The senior is emerging dependence. And our concepts are about who we are, what we are, our identity in the world is really shifting. Okay? Drugs are easily available to both groups. Last week I was talking with some high school counselors, and I was just stunned to discover in high schools that the availability of just a panorama of illicit drugs is incredibly easy. For the elderly, prescription drugs are available through their provider, and it's without the stigma of an illicit or an illegal drug. And then the progression here. So think about an elderly patient who's been prescribed a pain pill for chronic arthritis and neuropathy, and it doesn't work, so the doctors step up the dosage or step up the type of medicine, and we can quickly see that escalation to dependency. Not terribly different from the steps that adolescents have in progressing in terms of they need a bigger and bigger effect to progress to dependency. And then I neglected to put number 4 here, which I think is far more specific to motivation for the elderly, but just the whole syndrome of loss as we age, loss of our identity occupationally, loss of our friends, loss of our health, loss of our independence, very powerful issues. The patient I mentioned earlier, that lady had lost a son in 1988 in October, and every fall her binge drinking would really escalate. So it's important to know that in terms of abuse of illicit drugs in the community for elders is quite low, and there might be a number of reasons for this, as I mentioned. They're done with it, they're burned out, perhaps they outwardly deny it, or there's been the hand of God in terms of selective mortality. They've abused it to the point of premature death. But quite simply, starting up illicit drug abuse in the elderly is very rare. We may see that change with the baby boomer cohort. So, a repeat, studies indicate elderly patients, both women and men, at least a quarter of them regularly use a psychoactive drug. The most commonly used prescription drugs in the elderly are, as you might imagine, cardiovascular drugs, but followed number 2 and number 3 by painkillers and psychoactive drugs. And then, of course, depending where you look, you'll find a higher incidence. If you look in medically hospitalized geriatrics, we're going to see the use of sedative hypnotics there, 40 to 50%. And then if you look at geriatric inpatients, it's going to pop up to 80%. Who's at risk here? Nice data on risk factors. What we see, particularly for sedative hypnotics, it's generally someone who's female, they're alone, they're widowed, they're divorced, they have a history of psychiatric illness, perhaps depression or anxiety, or a past history of substance abuse. they take many medicines, and they have chronic medical problems. That's somebody who's clearly at risk. So what goes on here in terms of how these prescription drugs really get out of control? Well, a number of factors. The passivity of the dependent senior. I mean, particularly the greatest generation, they're not going to question the doctor. And we may see double prescribing. The primary care is giving a sleeping pill, so is a specialist. It's just not in their nature to question the treating physician. I recommend to a lot of my elderly that if they're not sure about a treatment or a procedure, that I want them to lean forward, look into their doctor's eyes, and simply say, if you were in my shoes, would you do this? Would you take this medicine? Kind of forces some honesty there. Poor communication regarding dosing. You think about some of the regimens for prescription drugs for any of us. Take this pill 4 times a day for 10 days, okay? And it's on the side of the bottle. The ones I like with anti-anxiety medicines, take 1 pill as needed for severe anxiety every 6 to 8 hours. Well, that's subject to a wide range of interpretation. What do we know about the elderly when they get together? Well, my doctor said, take this for my arthritis and it helps me, so let me give you a couple. We'll share and swap. Have a dearly beloved family member who takes several medicines, and she puts them all in one container. It sort of looks like just a polyglot of medicines. How she keeps it straight is beyond me. Misuse of over-the-counter medicines. I mean, there's no physician directing us here, and these drugs have lots of interactions, okay? And as we mentioned earlier, the most common are sedatives, laxatives, and analgesics. The do something directive for physicians. Here's an older patient presenting with a physical complaint. They expect a result. And the doctor, of course, we want to uphold the patient-physician contract. We don't simply want to counsel them or observe them. We want to do something, okay? It's an interesting piece. There's a brilliant article in Psychiatry entitled don't just do something, but stand there. So kind of wait and see, as opposed to always make sure the patient leaves with a prescription. And then the last one, and this is truly tricky territory, defensive prescribing. This is where a physician is prescribing medications to reassure the staff or the family about a difficult situation or a problem behavior. So they're not prescribing to the patient, they're prescribing to someone else and something else. And in the interest of time, this presentation, I think, is in its entirety. I'm just going to completely pass through diagnosis, treatment options, and we're going to kind of close on an optimistic note, recovery. There's good evidence that when elderly patients that have prescription drug abuse problems are identified and they're treated, they're detoxified or tapered, they're stabilized, and of course then the mission is relapse prevention, that if they can be entered into age-specific programs, we see this primarily in older alcoholics, that they have much better outcomes. Now, they're hard to find. Looked at some data last night. In 2006, they polled 13,750 treatment centers in the United States and Canada, and they found 212 that had age-specific programs. So they're hard to come by. There's a magnificent treatment unit in Florida for geriatrics called a Hanley Center, where the lady I talked about earlier actually went for treatment. And then we know that opioid-dependent patients, they seem to do better with opioid treatment. Here's what I'd like you to go home with, the final minute, take-home conclusions. Please be mindful. There's that wonderful buzzword of, I think, this year. Be mindful of the prevalence of substance abuse in seniors, prescription drug abuse, and their vulnerability. And then what do salesmen always say? Always be closing. Let's always be screening. Ask about use of alcohol, illegal drugs, use of tobacco, use of caffeine. Reconcile their medications. Collateral history from families, incredibly helpful. Brief interventions are powerful. It's amazing just simply making recommendations. Have you ever thought about abstaining? Have you ever thought about cutting down? As simple and as small as that seems, it's powerful. And then as we mentioned earlier, it looks like age-specific treatment programs, as rare as they are, they generally have better outcomes. This isn't like a sock that one size fits all. And then at all points in time, particularly with elderly patients that abuse prescription drugs, we want to zero in on phase of life issues which are primarily going to be centered on loss. And I'm sorry I went 2 minutes over. My apologies. And I think I'm told to take questions at this time. So slide over. So question 1 is, do you see a correlation between substance abuse and suicide? Absolutely. This is very well documented, particularly in the suicidology literature. So that patient who's most at risk for a completed suicide is an elderly male who's alone, who has a past history of alcohol use, has a past history of depression. He has a plan, and he is alone. This is, without a doubt, the most at-risk population. And then, let's just think about this from the media. Who have we recently seen end their life prematurely? We've got the Whitney Houston tragedy, and the coroner's report is out now. I think she was 47. So had toxic levels of Xanax and anti-anxiety medication, prescription medication in her bloodstream, as well as cocaine. I don't know what her blood alcohol level was, but we know that she certainly suffered the ravages of that. We have Heath Ledger. Is that an unintentional or intentional overdose with a multitude of prescription drugs and illegal drugs? So there's an incredible correlation between substance abuse and suicide. The second question, I'm grinning. How do you feel about medical marijuana? So I think that medical marijuana is legalized, if that's the correct term, in Colorado and California. And I guess I'll just give you the answer that you should have seen coming. I mean, I'm a conservative guy. I'm a Western medicine physician. When I was an intern, I did 3 months on an oncology unit where we would use government mandated cannabinoid to control nausea and vomiting, and in my opinion it was minimally effective. So I guess my opinion is simply I'd like to see research and data on it. I don't think it exists. I suspect that the states where this is widely used, that the demographic is younger people, and I would question what the medical necessities would be. So that's probably a Clint Eastwood answer. I'll just leave it at that. So I'm told that it's time to sign off.